Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. It's time for another episode of Evidence with Anne, and today we're going to cover the mammoth topic of the Term Breech Trial.
Yes, I've been looking forward to this episode. It always seems to spark some controversy. So I haven't been in this game long enough to know what it was like to work prior to the Term Breech Trial. If you've forgotten what we spoke about in our vaginal breech episode, then I'll refresh your memory. By the 1980s, about 15% of breech babies were born by caesarean, about 75% of breech by the 1990s, and more recently, about 90% in 2021.
So let's get into it, the Term Breech Trial.
We'll chat about the study design and outcomes as usual. For this particular trial, there are definitely some strengths, limitations, and common themes that always come out when discussing this trial. We aren't trying to portray a particular opinion, just enough information so that you understand the trial and can discuss it if it were to come up in an exam question or teaching session. We'll start with the basics. The full name of the trial is Planned Caesarean Section versus Planned Vaginal Birth for Breech Presentation at Term, a randomized multi-center trial. It was published by Hannah et al. And published in The Lancet in the year 2000. The aim of this trial was to determine if there was a difference in perinatal mortality or morbidity for planned caesarean versus planned vaginal birth for breech deliveries at term.
It was conducted between 1997 to 2000 in 121 centres in 26 countries.
Wow, 26 countries. That's impressive.
I know. It was also a randomised controlled trial. Participants included 2,088 women with singleton fetuses in frank or complete breech presentation at term, with term being defined as greater than 37 weeks. The participants were randomised to planned caesarean or planned vaginal birth. So let's test your short-term memory, Carla. Can you do a recap?
Yeah, let's do it. The Term Breech Trial, otherwise known as Planned Caesarean Section versus Planned Vaginal Birth for Breech Presentation at Term, a randomised multi-centre trial. It was published by Hannah et al. In The Lancet in 2000.
I know this is trivial, but I remember the year 2000 because it changed practice at the turn of the millennia. The participants included over 2,000 women with a singleton fetus in frank or complete breech presentation.
That's a really good way to remember it. So the 2,000 women were randomised to a planned vaginal birth or planned caesarean section. When we spoke about breech vaginal birth in a previous episode, we discussed all the specific contraindications and labour management considerations. How are these pregnancies managed?
If they were randomised to caesarean, then this occurred at 38 weeks or more. If they were randomised to vaginal birth, then it was managed expectantly unless they required an induction or an indication for caesarean developed. There was a requirement for a skilled attendant at delivery. A total breech extraction was not recommended. No intervention was allowed until the fetus was delivered to the umbilicus, and if the head didn't deliver spontaneously, then it was delivered with either the MSV or forceps.
I'm assuming that the exclusion criteria was similar, like babies that aren't too big and babies who don't have a hyperextended neck?
Yep, that's right. Exclusion criteria included evidence of fetal-pelvic disproportion, judged to be clinically large or estimated fetal weight greater than 4 kilos, hyperextension of the fetal head, fetal anomaly or condition that might cause mechanical problem at delivery, footling breech, any contraindication to vaginal birth, or a lethal congenital anomaly.
So Anne, you said that the aim of the study was to determine if there was a difference in perinatal mortality or morbidity between the two groups. What were the specific indicators they looked at?
So the primary outcome was perinatal mortality, neonatal mortality, and serious neonatal morbidity. This included subdural hematoma, intraventricular hemorrhage or intracranial hemorrhage, spinal cord injury, base of skull fracture, peripheral nerve injury present at discharge from hospital, genital injury, seizures, APGAR at less than 4 at 5 minutes, a cord blood-based deficit, intubation and ventilation greater than 24 hours, tube feeding greater than 4 days, NICU more than 4 days, hypertonia at least 2 hours. Gee, that was a mouthful.
And the secondary outcomes included maternal mortality or serious maternal morbidity. This included a PPH greater than 1,500 mils or a blood transfusion, DNC for bleeding or retained placental tissue, hysterectomy, cervical laceration involving the lower segment if it was a vaginal birth, vertical uterine incision if it was a cesarean, vulvar or perineal hematoma requiring evacuation, DVT or PE, pneumonia, ARDS, wound infection requiring prolonged hospitalisation, maternal fever, organ injury, and other.
The analysis was an intention to treat. Interactions were investigated with multiple logistic regression. Groups were compared by means of Fisher exact tests for the analysis of categorical variables. Wilcoxon's rank sum test for the analysis of continuous variables that were not normally distributed. Carla, what were the results?
And for those of you who don't understand what Anne's talking about, we will do a statistics episode to explain those tests.
Absolutely. And if you don't already know the results, I'm sure you can guess them. Neonatal mortality or serious neonatal morbidity was significantly lower in the planned caesarean group, 1.6% versus 5%, with a relative risk of 0.33 and a p-value of less than 0.0001. The number needed to treat to prevent one death or severe perinatal morbidity is 14.
We already kind of touched on the implications of this outcome in our breech episode, so we won't go into that again right now. But basically, there was no difference in maternal mortality or serious maternal morbidity.
Summary time! The Term Breech Trial was published by Hannah et al. And published in The Lancet in 2000. The aim of this trial was to determine if there is a difference in perinatal mortality or morbidity for planned caesarean versus planned vaginal birth for breech deliveries at term. It randomized over 2,000 women with persistent frank or complete breech at term to planned vaginal birth or planned caesarean. The primary outcome was perinatal mortality, neonatal mortality, and serious neonatal morbidity.
Neonatal mortality or serious neonatal morbidity was significantly lower in the planned caesarean group at 1.6% versus 5%. The number needed to treat was 14 to prevent one death or severe perinatal morbidity, and there was no difference in maternal morbidity or mortality.
Okay, I think it's time to get into the nitty-gritty of this study. One of the important factors of this study is that it was conducted in both high and low income countries. One of the points the authors made is that there was an equal proportion of patients from countries with high versus low perinatal mortality rates. And that was one way that they distinguished between the different countries involved. I'm assuming that the reasoning for this would be to make the study quite generalizable.
One of the limitations of this meant that there were discrepancies in the labour management as well as the resources available. For example, continuous electronic fetal monitoring was not required, and as we know from our breech vaginal birth episode, that this is a recommended part of labour management in breech. Not all facilities had access to immediate caesarean section, and there was also no requirement to have an ultrasound for assessment of fetal weight or whether there was any hyperextension of the head. In fact, 40% of women in the Term Breech Trial did not have an ultrasound. One consequence of this was that 3.7% of the babies in the planned vaginal delivery group were actually cephalic.
Another advantage of this study design was the large sample size. Given that only 3% of term babies are breech, I thought that over 2,000 patients was pretty impressive. Conversely, because of the large number of centres involved, this meant that over the study period, there was on average only 4 women each year enrolled in the study at each centre.
Now, let's discuss the perinatal mortality.
Oh, that sounds cheerful.
Sorry, but I thought we should get into all the details. So there was a total of 16 perinatal deaths. 7 of these were due to undiagnosed FGR. 6 of these were due to a difficult vaginal delivery, and 2 of the deaths probably occurred prior to enrolment. Regarding the experience of the accoucheur, 97% had an experienced practitioner at delivery, 70% had an obstetrician. I think this is important when you're considering the results, is that not all of the perinatal deaths were secondary to a difficult vaginal delivery.
Good point. Another point to consider for this trial was the outcome markers used for morbidity. Some commentary on this point was that the outcomes used for morbidity did not correlate well with the data at 2 years. Regardless of the mode of delivery, there was a 97% chance of a normal neurological child at 2 years old.
Regarding the randomization, there was no blocking of randomization. So this meant that each centre didn't contribute equally to the numbers of vaginal births versus caesarean section. Blocking is usually used in multi-centre trials.
Okay, so does this mean we disregard the findings from the Term Breech Trial?
Definitely not. I mean, we're probably never going to be able to have the same study design done again, so it's important to interpret the results of this trial within the context of the study design and the setting with its limitations. There was a little bit of a knee-jerk reaction, again, not necessarily unreasonably, from the obstetric community to change practice to recommend caesarean for persistent breech at term, or an ECV. And as we know, there certainly has been de-skilling the area of breech vaginal birth. There are certainly now courses, such as the BABE course, to assist in upskilling accouchers in breech vaginal birth. Subsequently, guidelines, including the RANSCO guideline, have changed to stipulate that there are certain requirements that are required for a safe breech vaginal birth.
Okay, so time for a final recap. The Term Breech Trial, or planned caesarean section versus planned vaginal birth for breech presentation at term, a randomized multi-center trial. It was published by Hannah et al. And published in The Lancet in 2000. The aim of this trial was to determine if there is a difference in perinatal mortality or morbidity for planned caesarean versus planned vaginal birth for breech deliveries at term. It randomized over 2,000 women with persistent frank or complete breech at term to planned vaginal birth or planned caesarean. The primary outcome was perinatal mortality, neonatal mortality, and serious neonatal morbidity.
Neonatal mortality or serious neonatal morbidity was significantly lower in the planned caesarean group at 1.6% versus 5%. The number needed to treat was 14 to prevent one death or severe perinatal morbidity.
Thanks again for listening to us. Catch our summary slides on Instagram at The Uterine Sound, our website, theuterinesound.com, and email us if you've got any questions, queries, or you want to fact check us at theuterinesound@gmail.com. We love hearing from you.